Hi, my name is Stephen Gardner. I'm the president of OrthoSelect. OrthoSelect is an orthodontic software company and digital lab focused on providing doctors with the tools they need to become more efficient and more competitive in their practice. To that end, we have spent the last several years developing DIBS AI, an advanced digital IDB platform using patent-pending artificial intelligence to simplify, automate, and shorten case setups and binding appointments, as well as reduce overall orthodontic treatment times. But rather than have you listen to me talk about DIBS AI, we thought you might enjoy hearing from your fellow orthodontists talk about their experiences with our platform. What follows is an unscripted roundtable discussion with 3 of your colleagues who use DIBS AI in their practice. I hope you enjoy hearing from their perspectives and how it might apply for you. Thanks for watching, and I'll be back at the end with a few concluding thoughts.
My name is Mylan Detweiler. I'm a Senior Vice President at OrthoSelect, and today we're visiting with Dr. Laura Bonner from Rogers, Arkansas, Dr. Brendan Cooney from Troy, New York, and Dr. Ed Lynn from Green Bay, Wisconsin. They are all users of DIBS or DIBS AI by OrthoSelect, and we would like to have an opportunity to visit with them today and learn more about their experience using DIBS. We're also joined today by Steve Gardner, who is the president of OrthoSelect. What I'd like to do is just start off and have each of you take an opportunity, maybe take a minute, tell us a little bit about yourselves, your practice, and how long you've been using DIBS AI. Dr. Bonner, let's start with you.
Sure, wonderful. I'm Laura Bonner, University of Iowa graduate in 2013, and I've been indirect bonding, since residency in 2011. I think after my first direct bonding experience, when I was exposed to indirect bonding as a process on plaster models, I was a convert from day one. And then in my current practice, I went digital in 2018. So I've been about 3 years now with digital indirect bonding. So DIBS, and then recently switched over to DIBS AI and won't go back.
Fantastic, thank you. Dr. Cooney.
Yeah, hi, I'm a Georgetown graduate, ortho and dental, and I've been practicing upstate New York now for a good number of years. I have 2 locations, and we've been using indirect bonding since 2016 with DIBS, since 2016. So we've been using it for a good number of years now, and it has been just a game changer in my practice and the growth of my practice. And it's been absolutely invaluable, not just from my standpoint, but my staff and patients as well.
Dr. Lynn.
Yeah, hi. I've been in private practice now after graduating from Northwestern University since 1999. I've been indirect bonding since 1999, and we actually helped SureSmile develop their indirect bonding protocol. So we were doing digital indirect bonding since 2015, but have had issues since Dentsply Sirona took over SureSmile with especially the indirect bonding side of things. But then we switched to DIBS back in December. We went live with you guys in December of 2020. So I think we've been fully integrated with now. I think I heard we submitted over 100 cases last month to you guys. Yeah, it's been pretty good. There are definitely some advantages to it that we really like.
Well, fantastic. So it sounds like a varying degree of experience with our product. I wonder if I could get you all to comment what your overall experience has been with DIBS. What are some of the pros and cons that you've had with using our product? Anyone, please jump in.
Ladies first.
Ladies first.
Oh, okay. Sure.
We'll mix that up, but
yeah, absolutely. So with DIBS, and I'll say OrthoSelect as a company, a big pro in my eyes is the customer service that you guys provide. I don't think a successful product would be possible unless you're asking for feedback. And you guys are constantly asking, what can we improve upon? How's this working? Here's a tip. Are you having any troubles? So that's one of the pros, is that, integrating this into the practice has been, I'll say, pretty seamless. of course, there's repositioning and bracket accuracy versus direct bonding and decreased chair time and things like that, which I think come just inherently with indirect bonding. And I think more so with DIBS, just with the quality of trays that you guys are producing. So on the cons end, sure, there's a lab fee, and I know that there's extra time aside from what you spend in the chair to get things set up, but I think that's pretty minimal when you look at the whole scheme of the, I'll say the quality of bracket placement, at least that I feel like I get versus when I direct bond.
Dr. Cooney, thoughts?
Yeah, I think the biggest con of the DIBS product for me is that I didn't have it sooner in my career. And I will tell you, for us, it came at the perfect time. It was one of these little flyers that came in the mail. I almost threw it out. I did a double take on it, and I decided to call you guys and take a stab at it. And at that time, you guys the DIBS was very, very interactive in helping us figure out how to kind of, get on board with this and try it out. And they were extremely, as Laura mentioned, extremely great customer service, great feedback, always available, answering our questions, et cetera. And from our standpoint, the overall experience with the patient is dramatically enhanced because of the efficiencies of it. The quality of the bracket placement is really terrific. The ability to deal with the software and really precisely do things and look at some of the outcomes. It's made me, I think, better. And I thought I was pretty good at direct bonding before this, but when I do direct bond now, I'm better at it now as a result of using DIBS and the software, because it's a great learning tool in terms of how you can deal with certain issues with regard to bracket placements and tooth morphology, et cetera. So it's just been a great enhancement to our practice at so many levels.
Hey, Dr. Cooney, do you recall a few months ago, actually it might have been a year ago or so, you'd sent me an email. Do you remember you told me something about you had a direct bond, but your staff was helping in the chairs next to it? And it was something like, by the time you finally direct bonded one case, they had done the indirect bonding with our trays, like 3 patients or something, the same amount of time. Do you remember that?
Yes, exactly right. I had three
That helps on
patients
time.
get indirect full arch bondings done, and I was still puttering along in the first one that I was working on. Exactly right. Yeah.
That's
Great.
good. I mean, that's one of the things we try to say is that, hopefully it's going to decrease the amount your bonding appointments should go down in terms of time. So,
Dr. Lynn, you've been using DIBS AI since, I think you said December last year?
December of last year.
December last year. So you're fairly recent. What was the learning curve for you in getting up to speed on using DIBS AI?
It was pretty minimal. We've been living in the digital world now for since Invisalign in 1999, and we've been moving teeth around. So just kind of learning the tabs to hit with you guys. Your software is, I think, very user friendly. And we really, like I said, we did 100 cases last month with you guys, and we've trained. We have probably about 15 assistants right now, and everybody's fully trained already. So that's in the last 6 months. So it's been a really easy, smooth transition with you guys. And I echo what Brendan and Laura say. Your customer service has been outstanding. I think that is one of the most important things with any company, especially with a startup company. I think you guys, like I said earlier, you guys listen, and you guys respond and make improvements quickly. That's also a benefit of being a startup company, but that one that listens. one that listens is the key. So yeah, we love it. Big pros for us is the fact that we try to get SureSmile to with their indirect bonding system to allow us to print in-house and be able to turn it around quickly. And there was definitely discussions about that, but once Dentsply Sirona took them over, all that stuff kind of got put on the back burners and came to a screeching halt. So right now, in all honesty, if we needed to turn around an indirect bonding in our practice, we could turn it around in 2 days. 2 days, that fast. We never could do that with SureSmile before in the past. We used to also have to schedule 3 weeks out. So that's a huge advantage for us, especially with summer coming around, and people want to get started right away. And we do not want to delay starts in the summertime for 3 weeks. We want to get them in as soon as we can. Cons, I've been through so many different technology startup companies. You guys, You guys have been great to work with. I haven't honestly seen any cons. Brendan, I like what you said. You know, you said you wish you would been doing it sooner. I mean, I've been indirect bonding, like I said, since 1999. We went through like 4 different types of versions of traditional IDB in our practice. And when we went to digital, it was just phenomenal. And the fact that we can print these in-house right now with such short turnaround time, and the bracket positions are precise. The cleanup, there's a little flash, but it's nothing terrible at all. It's easy to clean up. And Brendan, like you said, how could you have done full bondings in that period of time if you didn't have the IDB? That's clinical efficiency right there, you know?
Yeah. I think one thing I've appreciated is that the amount of involvement that you want to have in your own practice is variable. So right now, Ortho Select, you guys are doing the setup for me, and then I tweak things, approve it, and you're printing it and sending it out with, I'll say, a pretty decent turnaround time in that. You guys get your setups back to me real quickly, and then printing and shipping is adequate. So right now I'm delegating that to you guys. I look forward to bringing that in-house, bringing printing in-house, bringing setup in-house. But I like how it's not just one way or the highway. It's, hey, how hands-on do you want to be with the process and the setup?
That is feedback we got, because you have doctors like, I want to do all DIY. Let me use the software.
Yeah.
Let me do the printing. Let me load the brackets. We have other doctors like, I don't care. Just get it to me as soon as possible with the brackets loaded. And they don't, you know, you get both ends of the pendulum, and we're trying to do that. It does come down to that choice and those options, and how can we help you and support you. But we're happy either way, right? We're happy with Dr. Lynn, where they do everything. Dr. Bonner, right now, we're doing most of the work for you and then shipping it to you. We're happy with either side. And if you want to switch to 3D printing, you know, we can help you with that and support you and recommend printers and resins and all that fun stuff when the time comes.
Great.
Yeah, Dr. Cooney, I think you print, is that correct?
No, I do not. I still subcontract to Ortho Select to do a lot of that heavy lifting right now.
Okay,
Yeah.
all right.
Again, as Laura mentioned, at some point, that's kind of the next piece of the puzzle. But right now, we're fighting enough other fights right now. So that's one that, you know, to subcontract and have it done as well as you guys do it for us is certainly, it's an amortized cost that is negligible in the grand scheme of things from what we're doing.
It just depends on your office. I mean, there's some office, you just don't want to mess with it. I mean, 3D printing, Dr. Lynn's, they've got it down. But it's honestly, it's not the easiest thing in the world. There is a learning curve, and it takes a while to get that down, and the post-processing and learning how to load the brackets. So again, we're happy either way, right? But it just depends on the office. Do you have the space? Sometimes there's some smell with that. So it just depends what the doctor wants and what you want with your practice. But again, we're happy to support either side of that.
Let's talk a little bit about the time aspect. Dr. Cooney, you had mentioned that your staff was able to do indirect bonding much faster than you could do direct bonding with it. How long do you typically spend in the software doing case setups? And I know it probably varies a little bit depending on each of you, but if I could just go around and hear from you how long it takes for you to do a case setup.
About 5 minutes.
Yeah.
Yeah.
Dr. Lynn?
We have so we do everything ourselves. You guys load the brackets for us, segment and load the brackets, and then we take it from there.
Okay.
But no, you guys just segment. I'm sorry, you clean up and segment, and then we assign the brackets, and then we have our digital lab. They position it as closely as they think they can get it to, and then they let us know it's ready for final review. And I did 3 of them today while I was in clinic. I had 104 patients today. You know, and so it takes me probably 3 minutes in all honesty.
Okay, fantastic.
3 minutes, it's super easy.
How about the actual bonding appointment? How long are those taking you, and how's that compared to when you've done it direct bonding? Now that you're doing with DIBS, what's the difference there for you?
I only direct bond phase 1 cases. That's it. I don't want to direct bond in any full comprehensive cases ever again.
Dr. Cooney?
Typically, for a single arch bonding, it's 20 to 30 minutes from in the door to out the door. Upper lower is 7 to 7, 30 to 40 minutes from in the office to out the door.
And that's indirect bonding, you're saying?
That's indirect bonding. To do it directly, you know, I'm at the chair for 20 minutes. for a single arch, probably puttering around with it. So yeah, and the way that, and everybody works differently. One of the great things about your software and the protocols is you can scale to however you like to work. So my associate and I, we will set the cases up with 5 minutes to set up the actual brackets. But then from there, the next time I see the patient, when the wires are in and the colors are on, I walk over and pat him on the head and say, you did a great job today, Billy. I'll see you in 12 weeks. That's it. That's it. I'm not at the chair doing anything other than reassuring mom, telling the kid they're doing a great job, talk about their baseball game. And it's a qualitatively different experience than me being there bracket by bracket, pacing it, and then in a race to get to the next patient because I'm already behind schedule because it took longer than we wanted because the kids were fidgety, et cetera. So the quality of my interaction with patients and parents is dramatically improved. The quality of the bracket setups is super precise in terms of the ability to work with the software. So the entire experience in the patient, and we have a lot of parents who will say to us, that's it, you're done that quickly. When I have a brace on, I was in the chair for 2 hours or 3 hours, this kind of stuff. And I'm sure, Ed, you must hear that and more of the same thing. Parents have had a very different experience and they're gobsmacked by how, efficient this was for the kid. And they're worried the kid was going to have a hard time. The kid had a great experience. And it's a great conversation piece as well, as you can imagine at the soccer field when they're talking to the other mom whose kid was in the chair for 3 hours getting the braces on at the other practice down the street. So, yeah.
So it's a competitive advantage for you then, I guess.
Oh, I would say it definitely is. And parents want their kids to have a positive experience, right? And they don't want them to be, overly stressed on stuff. And when you can deliver that efficient and happy of an experience, staff time, our time, it's freed up so much time in the schedule that, it's allowed our practice to grow exponentially.
Okay. Some doctors I've talked to have shied away from doing indirect bonding because of concerns over accuracy of bracket placement. The concern that in the past that they're concerned that it just hasn't been as accurate as it needed to be. What's been your experience using DIBS in terms of how well the brackets are placed from the trays? Dr. Bonner?
Very, very accurate. The fit of the tray on the teeth, you can tell if the tray is fitting or not. There's one way that it fits. So it's a very, I guess, a positive seat that when you seat that tray, it's on right where it needs to. There's no rock, there's no slop in that fit. And then same thing with the brackets within the trays themselves. They're snugly fit in there. And so I don't have any concerns that from what I put digitally, if it was reflected in that tray, it's going on the teeth that way. So very accurate in my perspective. We've taken several patients that we have worked up into our full wire size and then taken pictures and compared it to our predicted outcome. And, aside from maybe a little bit more arch leveling on, especially the lower arch, I'm really happy with the predicted outcome, even though, we were talking about earlier that it's hard to get it 100% digital to real world to get those to match up. But as far as the big ticket items of vertical placement and mesial distal placement, I'm really happy with it. So.
Dr. Lynn, how about you? What's the action?
Traditional indirect bonding trays were done with some type of either PVS or silicone material, and we would use a hard outer shell. So you'd have to. It's very technique sensitive. You have to be careful with overseating and underseating. The 3D printed resin that we use with you guys, and I can't remember which one it is from Vision Tech, but it's a hard, rigid material, and it just basically. It doesn't like snap on, but it kind of sucks on. But then the great thing about that 3D printed resin material property is that when we heat it up with either a tooth dryer or the curing light, it softens up. So we just kind of peel it right off. So you can push down hard it's got to be from occlusal and from the buccal. Those are the forces that you want to have because you want to make sure you get it seated all the way down and you're forcing that adhesive into the 80 gauge mesh of the bracket pads. Light cure it. and then heat it up, and you just peel the tray off, and you got a really incredibly precise bracket. And I think that, it'd be nice if we could do some type of study where we are actually getting the brackets on in real life, and then intraoral scan those brackets with the teeth, and then do a superimposition of that patient with the digital setup. And then let's see what the precision is. But my assumption is it's gonna be in the microns,
Yeah.
under 100 microns.
Dr. Lynn, we have a white paper we need to send to you because we did that exact same. We did, I think it was 32 patients from 3 different orthodontists. It was ended up being, I don't know, four 800 teeth, somewhere in there. I don't remember how many teeth it was. And we superimposed them, and we looked at how far off they were between what our software said it was going to be versus what the actual scan was after they bracketed. What was the average, Myron?
It's about 0.12 millimeters
Yeah.
variation.
It's 120 microns.
Yeah, exactly. So you were right. But that's just a white paper. That was us kind of confirming to ourselves that it was accurate. But we do have plans, and we've talked to a couple of universities. We actually want to do a study and get that published and get that data out there. But from our standpoint, we're really happy to see that. Yeah, it took a long time, a ton of years, and a lot of R&D with 3D printers. Boy, we tried everything for many, many years, all the different resins to finally get this thing where it is today. But yeah, I totally agree with you.
One of the things I've learned about orthodontics is that doing repos is the bane of orthodontics' existence. What's been your experience with doing repos with DIBS AI? Have you found that it's been about the same, it's gone down, gone up? What have you experienced with that, Dr. Cooney?
Minus the highly rotated teeth. I mean, obviously
Yeah,
those.
obviously there's always going to have to be some, but just in general, what's been your experience on the repo side?
My standpoint, it has definitely, I'm sorry, Laurie, go ahead, Laurie.
No, you go.
All right.
Okay.
My experience, it's been we have very few repos to do other than, as you say, a planned repo due to an initial position of the tooth, which required it. I just am amazed at, as cases are finishing out, the level of accuracy we have, and the amount of, I'm not sure why I'm getting feedback. But the number of repos is definitely way down.
Dr. Bonner?
Oh, the only thing I have to compare to is my phase 1 direct bonding, and I would say it's less, but I don't necessarily have data from when I only direct bonded to then indirect bonded. So it seems less in those 2 scenarios for me.
Okay, good. Dr. Lynn, any thoughts on that for you?
Yeah, definitely less. And when you talk about those severe rotations, because of the 3D printed tray design, for example, when we were doing SureSmile IDB, they had a cap design that covered the labial, mesial, distal, and severe rotations. We'd actually have to take the bracket off. But with the DIBS tray design, I get to put on many more brackets than what I used to be able to do with IDB. And some of those you can't get into ideal position, but at least it's something on there, and I don't have to spend the chair time with the full bonding, direct bond it. And then, yeah, you just set it up for repositioning the following appointment. But definitely, repositionings are minimal.
Fantastic. Any financial benefits you've had from implementing DIBS in your practice? Have you noticed any benefit there, Dr. Cooney?
Yeah, for me, it had to do with my circumstances. I had opened a second location in 2012. And by 2015, 2016, it was starting to get quite busy, and I was getting very busy. I was by myself, 2 locations, and I was maxing out what I could do because of the amount of physical time it took. Along came DIBS, and that completely transformed my work schedule because I freed up a lot more time for myself for new patient exams, et cetera. I could get all the bonding done as the practice was growing because I was able to delegate a lot of that to my staff. I had complete control over all the bracket positions and the overall quality piece of it that I wanted to have control over, but all the other pieces, the mechanics of the actual putting it on. And the way we looked at it, I think Dr. Lin, mentioned the digital workflow that he's been working on for a long time. It's the same sort of thing with what we're doing with, the Invisalign stuff is, you take a scan, you get a digital model, you create the occlusion you want, and you say print it, and a bunch of trays come in, whether I put the tray in or the assistant puts the tray in or the hygienist puts the tray in, you're going to get that accuracy that you designed digitally. And so to be able to scale that and have that sort of vertical integration of digital workflow from not only your fixed appliance cases, your Invisalign cases, but also in your fixed cases, now you're doing the same workflow, the same work stream. And that really makes sense to a lot of your staff and our team members in terms of how efficient that process is. So it's taken a lot of the variables out because it's doctor controlled and doctor directed, but the ability to use a digital technology to be able to maximize the efficiency with which you do things, it's opened up tremendous growth opportunities for us. So our practice has continued to grow quite dramatically as a result of the ability to integrate the digital indirect bonding system from DIBS.
Okay, fantastic. Any other thoughts on that? No, okay, great. Well, so you've been using DIBS now for a while, all three of you. What advice would you give to your colleagues who are thinking about making that transition from direct bonding and going and doing indirect bonding, and specifically going to use DIBS in their practice? Dr. Bonner, what do you think?
Sure, I'd say,
tell your friends.
I'd say jump in and try 10 cases and then ask procedural questions of, you guys, and then obviously I think any one of us I'd be happy to help at least with products that I use that, we've tinkered with and that have been real successful and curing times and whatnot. So I guess my suggestion is try 10 cases, see how it goes, ask a lot of advice on just how to do it step by step, and then decide after that if they think it's something that they want to integrate full time, and I'd imagine that they would. So. Okay,
great. Dr. Lin, what advice would you give?
Just do it. Just do it.
Yeah.
All
Once
right.
you do it, you won't go back.
Great. Dr. Cooney?
Yeah, I would agree with Dr. Lin and Dr. Bonner on that. It's you just got to get in and do it. And I think that one of the things that holds everybody up, I think the same thing with like Invisalign when it first came out, the lab fee and these kind of things. And I think that it becomes a chicken and egg question with that, because you're not gonna be able to free up the time to be more productive if you're still chained to the chair, direct bonding every bracket on every tooth. So it becomes a self-fulfilling prophecy that you can't grow the practice as well because you're still physically, analog doing every single step. You're treating the appliance rather than treating the patient with your time. And that's the most valuable resource we have is our time, our diagnostic ability, our treatment planning ability. So the more you can free that up, the more that these other things just kind of go away. If you're really, really busy, as I was, it was a godsend because it freed me up to grow the practice more. If you're not that busy, it still is going to open up, I think, an opportunity for you to do things differently, so you can continue to scale and grow in a more efficient manner because you've got this workflow that's kind of built in that's hyper efficient. I think it can only give you a competitive advantage in terms of your overall practice management and the patient experience.
Or just go golfing more if you don't want more patients.
That's I agree with you. Right? Take a day off and go golf. I like that. I like what you think, Steve.
Right.
I hope you enjoyed hearing about how your peers incorporate IDB into their practice. We are really excited about what DIBS AI has to offer and how it can help transform your practice. We have designed it to be both simple to learn and incredibly powerful to use. Be sure to stop by the OrthoSelect virtual booth where we can give you a demo of the DIBS AI software and answer any questions you might have. You can also visit us at dibsai.com for more information. Thanks again. I hope you enjoy the rest of the conference, and I look forward to meeting with you in person next year.